Hello, welcome to the 10-7 podcast, where we bring the science of emergency medicine to the day-to-day life on the truck. So sit back, relax, and join us for our conversations. Welcome back to the 10-7 podcast. I know that it's been a few years since we put out an episode, but we're finally bringing it back. I'm Hunter Shifley. I'm a critical care paramedic, and today I'm here with Andrew Gist, who's one of my coworkers, and he's also a paramedic.
Hello. Good evening.
I'm going to go ahead and get our legal disclaimer out of the way. The viewpoints and opinions expressed in this podcast are of the 10-7 podcast alone. They are not meant to supersede your local and or service protocols and guidelines. Okay, so Andrew, why don't you go ahead and intro what we're going to talk about today in the article?
Today we're going to be talking about everybody's favorite drug, at least EMS's favorite drug, ketamine, which I have not really had the pleasure of using on any calls yet, but one day.
One day, you know.
Yeah, one day. But today, specifically, we're going to be talking about its implication in status patients or status epilepticus. There's not a ton of studies out there for this specific. Well, there's obviously studies for using it in status, but we'll get to the specifics later. But we're going to be going over the specific case study called Refractory and Super Refractory Status and Evidence for the Use of Ketamine. It was conducted by Dr. Luis Espinoza, Dr. Mario Gomez, Dr. Adrian Zamora, and Dr. Daniel Milano Franco. I apologize for any potential butchering of names.
Yeah.
But
that epilepticus is a hard word to say.
Yep, yeah, we're going to be saying status, that's for sure.
Yep. Okay, so let's go over the case now that we have it introduced. We need to understand that this is not an RCT. All right, we know that RCT is the best form of evidence that you can use in medicine, right? The double-blind RCT.
Most widely accepted.
Most widely accepted, for sure.
That's the standard.
But here's the thing. There are essentially zero, zilch, randomized control trials on ketamine, particularly in status patients. I'm not sure why that is, but it is what it is.
Money.
Yeah,
no, I don't know.
Yeah, you know, it might be. Who knows?
Who knows?
Anyway,
Everyone's
so we just
too
need to
busy.
recognize that the validity of this trial, its case studies, and its evidence is retrospective, and it's not confirming 100% scientifically. You know, we don't have p-values, we don't have things like that. But it's something to get us thinking. We need to start thinking critically, and I think this paper does a good job of that, and it introduces an idea that I wasn't familiar with and brings up a good point that we could start using it for. So the meta-analysis, rather, was done, and they reviewed a database where they had 1,535 records to pull from. Of that, 1,497 of those records were excluded.
Wasted, you could say.
Yeah, wasted.
They were wasted down the sink.
For one reason or another. So that left them with 68 reports that they had to pull from out of the original database. Out of that 68, 38 were only reviewed. Only 38 were reviewed. The reason that the rest weren't reviewed was because 6 were ineligible due to population, 6 were abstract only, and 6 were duplicates. The dates of publication for these case studies range from 1990 to 2022.
That's a long time.
A long time.
Medicine changed so much.
Oh, yeah. I mean, it can change tomorrow. You know what I mean?
Yeah, and it will.
It will. But so basically the result of this meta-analysis showed that ketamine as a third-line drug after benzos and anticonvulsants is effective in controlling RSE, or refractory status. So those status patients that The benzos aren't working. The Keppra's not working.
They've been taking their medicine for years, and it's
Right.
not working anymore.
There's no alcohol on board, stuff like that, right?
Hopefully not.
Hopefully not. Even if there is, we know those patients are going to seize, and they're going to seize like crazy.
Yep.
But, Andrew, I'll hand it over to you if you want to talk a little bit about the pathophys of RSE.
Sure, I'll stumble through this. So, once a patient has reached the point of status, where they've been seizing for 5 minutes or more, or they haven't returned to a baseline within 5 minutes.
It's not 30 minutes anymore?
It's not 30 minutes anymore. Thankfully, it's not 30 minutes anymore. Yes, once they've reached the point of status, the cell membrane experiences a decrease in GABA receptors and an increase in excitatory receptors. Specifically the excitatory receptors of NMDA, the receptor that likes to put glutamate in the two neurons or the neuro cells. The status qualifications in status epilepticus refractory to first-line treatments such as benzos. So excitotoxicity is characterized by neurological death and induced by excessive release of glutamate over an activation of its receptors. So obviously, just summarizing it, if there's too much glutamate in the exciter glutamate, if there's too much of it in the cell, for too long, it can cause cell death. Hence why they stopped waiting 30 minutes and changed it to 5.
What's a 30-minute seizure?
Yeah, it's basically putting your brain in an oven, but yeah, thankfully they changed that. But too much glutamate in the cell can cause an increase in the increase of calcium concentrations and promotes lipid peroxidation of the cytoplasmic membrane, endoplasmic reticulum, and mitochondria, causing cell death.
Right. Okay. Now a little about the NMDA receptors. The NMDA stands for N-methyl D-aspartate. Not that that's super important for us pre-hospital folks to know, but we need to recognize NMDA. Okay, those receptors belong to a family of receptors called inotropic receptors, and these receptors are coupled to an ion channel which allow the entry of various ions and mainly calcium. Okay, now the places in which they do that are the places we just talked about. Your cytoplasmic membrane, your endoplasmic reticulum, and the mitochondria. All right, which is why it goes along with causing that cell death from RSE, right?
Yeah.
That's how it can affect those.
Ketamine doesn't affect the GABA receptors on that cell, does it?
No.
It's just NMDA.
It's an NMDA antagonist.
Yeah.
Okay. The locations of these receptors are located in the medullary, thalamic, limbic, and cortical levels. Some of the locations of those. Now, ketamine, it is, like we just said, an NMDA antagonist. It particularly targets the regions that we just talked about, the medullary, thalamic, limbic, and cortical levels. But it does this, and it gives the medication the name dissociative anesthetic because it interferes with the sensory afferent flow to the central nervous system's higher centers, affecting pain, emotional response, and memory.
So basically, the body still could be receiving pain, but it doesn't realize that it is receiving pain.
Right. So yeah, it's not going to block the nerve signals, right?
Yeah.
Saying, "Oh, you're hurting."
It's not an opioid.
Right, but it's not an opioid. But that's where we're able to use this on excited delirium patients. Those patients who are just kicking our tail in the back, out of their mind. It's that dissociative aspect of the medication which allows us to do that. And what the ability to do that with the ketamine also doesn't take away their airway, right? The breathing center of their brain. It doesn't knock out their respiratory drive.
No, it's not going to cause apnea.
Right. They may be drooling to beat the band, but
you know, we got a solution for that, which we will get into later.
Okay. Ketamine also has some effect on opioid receptors. Like we just said, it's not an opioid, and it's not going to trigger a response like an opioid would from the opioid receptors, but it does have the ability to bind to them. Okay. Some studies have shown that ketamine can affect different areas of the brain differently, but the administration of ketamine has been shown to increase the amount of pre-synapse glutamine, but lowers the extracellular glutamate. Sorry. Might seem like a nitpicky difference between the glutamine and glutamate, but it's a difference that we need to know because that glutamate is what's causing the cell death, right? Allowing the calcium to get into the cells at too high levels. This study that I'm referencing, talking about the glutamine and glutamate, suggests that ketamine interferes with the TCA cycle, which is what converts glutamine to glutamate. And there was also another article I found published in Molecular Psychiatry. It's titled, Ketamine Decreases Neuronally Released Glutamate Via the Retrograde Stimulation of Presynaptic Adenosine A1 Receptors. I have been unable to link the correlation of the adenosine A1 receptor to the TCA cycle, but I don't know. It might have something to do with that. It might not. It might be something completely separate.
The only thing I know about adenosine is that they think that epileptic patients have a low amount of adenosine that's causing their seizures, and I don't know how that links with the TCA cycle at all.
Gotcha. Either way, regardless, that's what ketamine does, is it affects the adenosine A1 receptors in the presynapse regions of the neurons and the axons, okay? Now, ketamine is derived from the same cyclohexenes as PCP.
Yeah, it's like basically the same shape, isn't it, molecularly?
It's very similar. So that's why the ketamine is also a cyclohexene. But it just reminds me, it's so crazy because I just thought about this. In high school physics, my professor, or my teacher, he'd always, let's say we were talking about an angle going uphill, pushing something uphill, and it was some astronomically huge weight boulder, and he'd draw a little stick figure on the board, pushing it up. He's like, we're going to assume this guy's on PCP. And I don't necessarily put the two together with ketamine, because ketamine, knocks people out.
Yeah.
But it's a similar structure molecularly.
Yeah.
Both derived from cyclohexenes.
I would just say he's on Flocka.
Yeah, Flocka.
Does Flocka exist anymore?
I don't know if it's still around or not, but
was it ever real?
Oh.
We'll get back to that. Maybe there'll be another podcast.
Oh, it was real. I've seen it. Anyway, ketamine has a 10 to 30% plasma protein binding ability, which is important when we administrate it, because we need to start thinking about, other medications and things that, like, for example, the perfect example, we give a patient Versed. That has, don't quote me here, I think it's 60%. Let me look. But either way, the importance of the plasma protein binding is because if the medication is bound to that albumin, which is the primary plasma protein, it's not available for the body to use, right? So we need to be cognizant of that. But the ketamine only has a 10 to 30%. So that means 10 to 30% of what you give is going to be bound to the albumin and the plasma proteins.
Does that...
Oh, no. Midazolam has a highly bound, greater than 96% plasma protein.
Okay.
So it's really attracted to those albumin and proteins.
So does that correlate with his efficacy?
Yeah. So So let's say you gave ketamine and then you give midazolam.
Yeah.
There is going to be, what's going to happen is there's only so many seats on that albumin. And that midazolam has a higher affinity for it. So it's going to kick that ketamine or any medication they take daily off of that albumin and take its seat.
It's going to take over.
Right.
Okay.
Which means there's more medication of, like, let's say you gave ketamine. There's going to be more ketamine available to the body than there would have been before you gave the midazolam. Right?
Yeah. What's the protein binding of Valium?
I'm not sure. I know fentanyl's pretty high as well. And that's kind of where you get into the thick of it with the plasma protein binding, is if you give two medications that have a very high plasma protein binding ability.
Yeah.
Because you're going to potentiate the other one. That's where we're getting into potentiations of medications.
Gotcha.
You give the Versed to stop seizure, and then you give some fentanyl, which is also high. It's going to kick some of that Versed off of its seat, but it's also not going to fill the seats completely.
Yeah.
So now you have more than you anticipated of the fentanyl and the Versed available for the body to use. Right. So that's something to think about. Now, ketamine, like I said, it's 10 to 30%. It's pretty low, actually, really low plasma protein binding ability. But you got to think about what other medications you've given and what other medications the patient takes every day, right?
And if they're actually taking it.
And if they're actually taking it. Compliance is 100% out here in the streets.
And if they're not drinking with it.
Right. Yeah, alcohol helps everything, right?
Well.
Lowers your seizure threshold. Can't do any harm. But anyway, ketamine is converted to norketamine in approximately 2 to 3 minutes, and it reaches peak conversion at approximately 30 minutes. So why does that matter?
I think that happens in the liver, right? I think it's processed in the liver.
That might be where it's metabolized,
Yeah,
but it's converted. The effects of ketamine are actually the effects of norketamine, right? So you're not going to get any effects until that ketamine is converted into the norketamine. And I believe that was IV administration. But either way, that has to be converted into norketamine. Now, why is that important that it has to be converted once we administer it? Because benzodiazepines have the ability to prevent ketamine's N-demethylation. And what that does is the N-demethylation is what turns it into norketamine, right? It takes off a methyl group from the ketamine, and that turns it into norketamine. But benzodiazepines can prevent that from happening. And what's the one thing we're giving on all seizure patients, especially status patients?
Lots and lots of benzos.
Benzodiazepines. Something to keep in mind. Now, there does need to be a cautionary note. Ketamine is not harmless, but it is pretty useful. But ketamine can prevent norepinephrine and other catecholamines reuptake, right? So it's not necessarily important for seizures, but in other uses of ketamine, we have to be careful because let's say you have a septic patient whose catecholamines are already in the tank, they're decompensating, their blood pressure's 70/40, right? And they're unresponsive, and you have to tube them for one reason or another. You have to RSI them. That ketamine can actually lower the blood pressure. You're not going to get that stereotypical bump in blood pressure that you get with the ketamine, because ketamine does release catecholamines, which is why we get that bump in blood pressure. But what it also does is prevent the reuptake of them. Mm-hmm. So if their stores are already, towards the toilet, you're just going to flush it down the toilet. You know what I mean?
Yeah.
Because they're not getting anything back.
So the plasma protein binding of Valium is 98%.
98%.
Yeah.
I know benzos are really high. But so it's just something to keep in mind with that.
Yeah.
Now, why is this article that we're covering important? How is it applicable to us on the truck or, in the helicopter, if you're in a helicopter? How is it applicable to us? Well, at least at our service, and I think it's the appropriate intervention, We RSI status patients, not because we think that we're stopping the seizure, because we're not. We're not stopping the seizure by sedating, paralyzing, and intubating these patients. But what we are doing is controlling their airway. Because once we get them in the back of our truck, our job is to try and fix them. And if we can't fix them, minimize the damage, right? And one thing that can go wrong with these status patients is aspiration. They vomit. Their secretions build up. And that may not kill them right away, but they're going to get aspiration pneumonia and make it even harder. Now the doctors are having to treat the aspiration pneumonia and the seizures.
Now you're having to write into your report why you didn't tube them.
Right. Justify why you decided not to take their airway.
That's like pretty much our number one job is to control an airway, right?
Right.
Yeah.
Breathing,
Breathing,
airway circulation.
Yeah, that's anyway.
ABCs, BAC, whatever you want to do. It's in there. Breathing's in there. Airway's in there.
Yeah.
But that's why I wanted to talk about this, is because we can use it for induction and continued sedation, right? We have a dose of 1 to 2 milligrams per kilo for induction, IV or IM. I prefer IV because it's faster onset. And with that, you're getting the dissociative anesthetics of ketamine, that twilight sedation, that where they're not going to remember the tube, they're not going to be fighting you. But it also takes care of analgesia, their pain, because intubation's painful. And then also, if we look at this paper, we could also be stopping the seizures, or at least attempting to stop the seizures, because we know if they're at the point where we've given the benzos, they didn't stop the seizure, or they stopped the seizure but the patient's still postictal, right? Because those are the qualifications for status.
Yeah.
Longer than 5 minutes, didn't return to baseline, all that stuff.
Yeah.
So now we're controlling induction sedation, and we're doing analgesia, and we have the possibility of stopping these seizures.
And if their catecholamines are at a normal level,
Right.
you're increasing their blood pressure
Or
after all the
increasing their blood
benzos you just
pressure.
dumped into
Right,
them.
because the benzos are going to make them hypotensive,
Yeah.
potentially.
Yeah, I mean, but they can potentially work hand in hand.
Right.
It's almost like you're killing two birds with one stone.
Right. And so I just think it's something to keep in mind that we can use. It's a tool in our toolkit, right?
It's a tool in your toolkit.
Well, yeah, but
for now.
But yeah, you can use it for induction. You can use it for continued. Now, the only caveat to this is the paralytic that you're giving for induction, right? Our service, paramedics have to use succinylcholine. Now, that has a duration that's short, like, 8 to 10 minutes, 12 minutes, something like that.
That's why we use it.
Right. But the ketamine's going to last longer than that. Right? So you got to be careful of that.
Significantly longer.
Be paying attention. Paying attention to those patients. I think the half-life, we looked it up, was 2.5 hours.
Yeah, I think that's what.
Something like that.
2.5 hours versus 8 minutes?
Yeah. So you got to be capable of getting that tube first attempt.
Yeah.
Right? And doing everything we can to better our chances of first pass success. I prefer to use VEC or ROC for induction, but if you're at the paramedic certification at our service, you have to use SUX, right?
Yep.
So it's just something to keep in mind. You need to watch your patient. They might still be sedated, but that paralytic may have worn off. And so it may be something that you need to address. Now, a lot of the case studies that were mentioned in this article did include a bolus, but they also were mainly focused on infusions, ketamine infusions, right? And that's after your benzodiazepines, after your Keppra that we don't carry, that I don't think most ground trucks carry Keppra, right? So after your benzos, doing the infusion, that's something to be considered as well. There's nothing wrong with an infusion. It'd be great if you had a pump. If you don't, use a dial flow. You definitely probably shouldn't be doing a gravity drip of ketamine.
Yeah, and that's I can imagine the most ground
What's
units.
going on? Oh man.
That's. I can imagine that any ground paramedic listening to this is like, come on, man, we don't have the money for pumps.
Yeah, pumps. What are those?
That'd be great. That'd be cool.
If we could get a pump, we're already at the hospital.
Yeah. Baxter pump, if you're out there, you make a nice little pump that we could use on a truck. Hit us up.
Yeah. But there are some side effects of ketamine that we need to talk about again. Ketamine can cause increased mucus production, right? You get that extra salivation. If you've ever used it for excited delirium and you've driven to the hospital, the patient's going to be sitting there and have you ever had them drooling, falling out of their mouth? You know what I mean? That's something to be aware of.
If you're tubing them with sucks and ketamine,
right?
That's
yeah.
There's gonna be spit all over the place.
Salad technique all day, huh?
Yeah.
But also, you can get laryngospasms with ketamine. Now, I did watch a video. I forget the physician's name. If I find it, I'll put it in the notes. But the physician was talking about laryngospasms from ketamine, and he said that there was a point right at the mandible, the joint of the mandible, a little bit further back under the ear. You put pressure and you rotate your finger, it can release that laryngospasm.
It's almost like a trigger point.
Yeah. He showed a video with a McGrath or King Vision or some video laryngoscope of the vocal cords, and you could see the laryngospasms. You weren't getting that tubed. And then he performed that maneuver up here by the joint of the mandible under the ear, and you could immediately watch it just relax, and he was able to pass the tube. It was very effective, and that's something else to keep in mind that could happen.
Yeah, the things you learn in med school.
Yeah, right. There was one more.
There's another way to reduce spasms?
No, not spasms.
Nebulized lidocaine.
Yeah, that'll do it. That'll do the trick. Yeah. Gosh.
It doesn't. I don't think we mentioned that ketamine was thought of to significantly increase ICP, and studies are kind of showing that it's not quite as bad as we thought.
Right. So what happened was, from my understanding, ketamine used to cause such a massive catecholamine dump that it would increase ICP, right? Because ICP is your MAP minus your cerebral perfusion pressure, and so if you increase your MAP, your cerebral perfusion pressure doesn't change. You're increasing your ICP, right? So they reformulated it, and that's not as big of a deal now. It still happens. I still see the patient get a little hypertensive with ketamine, but I don't think it's as bad as it used to be. It's kind of like amiodarone, how they used to talk about the hypotension that it caused, and they reformulated it, and it doesn't cause it as severely now.
Medicine changed again.
Right.
And ideally, if we're using this the way we're supposed to, then hopefully their blood pressure's a little not on the lower side, but
well, I mean, you're already going to have given those benzos, and
it's bound to come down a little bit.
You never know how many doses the person's gotten.
You don't know if they took their medicine that day.
They may be on Valium, they may be on some type of anti seizure medication, but it's just something to keep in mind, that it will increase their blood pressure. Do you have anything else you want to say about ketamine and RSE?
No. I wish I could play with it.
Yeah.
Seems like a
one day
fantastic drug. Yeah, one day.
One day.
Definitely.
But this, again, it was just to get us to start thinking critically, right?
Yeah.
This is by no means saying go out here and use this on every patient. You better do this or else. That's not what this is saying. This is just a study or a meta-analysis that just gives us a little bit more insight to the possible usage of ketamine and my argument for its use in RSI and our status patients.
potentially could be more efficient. You know,
Right.
it's
3 birds, 1 stone, right?
yeah. If we can avoid turning their blood into just this, medicine soup
Right.
of, it's overall it's just better for your patient.
Yeah, better for your patient. And that's what we're here for. We're just here to start getting us to think critically and to do better for our patients. And like I said, if we can't fix whatever's going on, we minimize the damage and get them to the hospital, and that's our job, right? Ultimately, we'd like to fix it, but obviously, oftentimes there's things we are limited to on the truck, and we can't fix it. But what we can do is minimize the damage that occurs.
It's nice to think that we could potentially have another tool towards that.
Right.
I remember working as status kid, and we called to the only pediatric ER we've got for med control and said, all right, we maxed them out on benzos. They're controlling their airway for right now. What else can we do? I've got Versed, Valium. They're like, Keppra. I'm like, okay, we've got Ativan, Versed, and Valium. What do you want us to do? They're like,
Keppra, I don't think you're hearing me.
Like, no Keppra. There is no Keppra anywhere here. So they basically said, yeah, just drive faster.
Yeah.
And I don't blame them.
Right.
I mean, they had kind of talked about, well, if you have to give Versed, I guess you can, but prefer not to.
Yeah.
But yeah, it'd be nice to have ketamine as a potential second or third line. Pediatrics would be second line, I guess. But
that reminded me of another one, that the seizure patient I ran that I intubated a status patient, and one of the side effects I was trying to remember, the seizure-like activity.
Yes.
Yeah. So when you give that's a possibility. Kind of freaks you out. You just gave it to RSI, a status patient, and you gave paralytics with it, and now, for some reason, they're shaking.
Yeah. It's
like, what do I do?
It's another flavor of pseudo seizure, I guess.
Yeah. Do I give more benzos? Do I give more ketamine? What do I do here?
You give them to a doctor.
Get them to a doctor. That's exactly what I did, man. Yeah. I was in the ambulance bay. I'm like, well, this is what's happening.
I don't get paid enough to deal with this. Here you go, doc. Good luck. I gave them everything,
right?
So,
and then this happened,
and now they're shivering.
But yeah,
that was just a side effect of ketamine.
Yeah,
right?
I looked it up afterwards, and that's a possible side effect of the ketamine, just to be aware of. But I think that just about does it for this episode. I appreciate everybody listening. If you have any questions, comments, concerns, corrections on anything we said, let us know. Also, I'm not going to be limiting this podcast to randomized controlled trials or meta-analysis anymore. If you have a case study or you just ran a cool call and you want to talk about it, let me know and we'll get you on. If you have an idea of what you want to hear for the next episode, let me know. But other than that, I appreciate you guys listening, and y'all take care.